presenter, Dr. Salman Kirmani is with us, and we'll be introducing him shortly, but just some housekeeping stuff to begin with. As you all know, that this lecture series is presented to us by the Pakistani Society of Medical Genetics, the National Institute of Child Health, and Janessa Medical University Alumni Association of the North America. All right, so some quick housekeeping rules. So audience should mute themselves if they're not already muted, out of respect for the presenter. And of course, please, if you have any questions, please put them in the chat box, as we'll be happy to take them on after Dr. Kirmani's talk. Lastly, we will have a Google form for all of you to fill out. We'd really appreciate all the information that we're getting, all the suggestions that you're sending us, and your feedback is really valuable in creating a robust program. So please make sure to fill it out, and I will be putting the link to the Google form periodically in our chat boxes. And man of the hour, Dr. Salman Kirmani. Dr. Kirmani is a medical geneticist and a pediatric endocrinologist at the Aga Khan University. He's an associate professor of medicine and pediatrics, and he also chairs the Division of Women and Children's Health and is the interim chair of the Department of Pediatrics. He graduated from the Dow Medical College and completed his residency and fellowship training at the Mayo Clinic, where he also served on the faculty. He is certified by the American Board of Medical Genetics and American Board of Pediatrics. He has been instrumental in developing the clinical genetics program at his institution and serves on the board of many patient support and advocacy groups. He has also authored over 50 peer-reviewed articles and also multiple book chapters, and is currently involved in numerous aspects of research at Aga Khan University. Thank you so much, Dr. Kirmani. I will let you take it on.
Wonderful. Aisha, why don't, that was your introduction. Do you want me to introduce you?
Oh, no, please. I think I've been introduced way too many times. People know me by now. Thank you very much.
Wonderful. Thank you so much for that very kind introduction. And thank you to the PSMG leadership for giving me this opportunity. I'm very excited to give this talk today. I'm a clinical geneticist, and I love talking about spreading the love for genetics around. And I think that's really what this talk is about today. A lot of geneticists can be very territorial and can say that, oh, this is the realm of the geneticist, so just refer the patient to us and we'll take it from there. But we know that the true practice of genetics is a partnership with multiple providers, whether it's the obstetricians or the oncologists or the pediatricians or the neonatologists. So the talk today is really geared towards a very wide audience. I know that there are non-clinicians within the audience as well, but I hope that the talk is fun for them too, because I really want them to get a broad overview of what we do once we diagnose someone with a genetic condition, because it just hits home the importance of getting the diagnosis accurately and then making a plan for the families. So without further ado, I will begin. And I'll have Aisha stop me once time is closing in on us. So give me 1 second. I'm just going to start. Yep, there we go. I have no financial disclosures. And the learning objectives of my talk are basically that I want the members of the audience at the end to be able to recognize presenting clinical features of common genetic syndromes. There are so many genetic syndromes that it's obviously impossible to cover everything. And even the best geneticists will not be able to recognize a genetic syndrome right at the outset. A lot of work needs to be done in most evaluations. But I want people to at least know what are the tests that are out there that can help them get to the diagnosis. And then after that's done, let's not just stop at the diagnosis, but why is it important? I'll keep asking that question again and again, as you'll see, as we'll present our cases, because the second half of the talk will really be more cases. And I'm hoping that that's very useful and enjoyable for you. So we'll begin. There's a bit of a lag as I'm trying to advance my slides, so just bear with me. Yeah. So why, what is the importance of a genetic evaluation? At the outset, you want an accurate diagnosis. That's really the cornerstone, because that sets you up for setting up the prognostic expectations for the family, as well as future planning with the multidisciplinary team. What we ideally want is to create a personalized roadmap that is there to prevent the complications and treat them appropriately, because we know that at least today, for most genetic conditions, we cannot cure them. But that may change within our lifetime, and we've seen a few genetic conditions be cured just over the last few years. Obviously, potential therapeutic options open up once you get a diagnosis. And then a huge part of this is genetic counseling for the couple, as well as for other family members and the reproductive options that they may have. So moving on. Sorry, I'm just trying to figure out how to deal with this lag, but it seems to be there. Give me 1 second. Okay, there we go. So the clinical approach. What we really want is that all of you really should take a thorough family history. We take detailed pedigrees, and we'll show you a little bit of how that's done. I want people to really be alerted to suspicious prenatal findings, because that can be extremely useful. And the obstetricians in the audience, like Dr. Shama, who's very, very experienced in this regard, will know that she's a key player in this regard, and we work very, very closely with her and people like her to help families make important decisions. The neonatologists and the general pediatricians and the family practitioners are extremely important, because they will be the ones doing the newborn exam, and that first look at the baby is usually done there, and decisions are made about whether a genetic evaluation is even needed or not. And then later on in life, presentations can be of developmental delay or intellectual disability. Sometimes the family members themselves will recognize that features are a bit unusual and different from other family members. And then anytime any clinician encounters an unusual pattern of findings, that alerts them that this may be a rare genetic condition. So, what are the essentials? A thorough review of the medical records is extremely important. It'll really save a lot of time and a lot of wasteful investigations if you've gone through that. And most people who come to genetics clinic come with some records. A detailed family history is the key, and our genetic counselors are really wonderful at doing that, and are partners with us as we do our clinical evaluations. A detailed clinical course is then required to really come to an accurate, at least an assessment of what's going on, what are the main set of symptoms, what chronologically happened first, because your differential is generated with that clinical course. And then obviously, after you've got a differential already going in your head, you approach the physical examination and you look for certain stigmata that are very characteristic of certain genetic conditions. Sometimes dysmorphology can be very tough. You've already had one lecture on dysmorphology, so and photographs of patients and close relatives can actually be very, very helpful. And these days with Facebook and WhatsApp and people carrying phones with them, it actually becomes quite easy to look at multiple family members and get an idea of whether the dysmorphism is part of this usual familial features or actually something related to a syndrome. And then obviously, getting an information on what has already been done before you embark on a genetic workup. So on the history front, again, I'm going to stick with the basics. Prenatally, you want to know about maternal health. You want to know if there were any risk factors over there that could somehow affect the health of the fetus. If there were any exposures to medications, there are so many teratogenic substances that can still be causing exposure to the fetus and lead to problems. Infections, torch infections, for example, can be problems. And then key ultrasound findings, things like excessive nuchal thickness or some other abnormality can really be the first clue towards a genetic diagnosis. The length of gestation is very important, whether things are, whether there is intrauterine growth retardation, etc., and so forth. So extremely important to get that. The birth history becomes very important too, because the mode of delivery can sometimes be key. There are certain genetic conditions where babies will not have a normal vaginal delivery and will be delivered by section. So that's important to know. The birth weight is important because there are some conditions that can cause intrauterine growth retardation, whereas others cause postnatal growth retardation. So it's extremely important to know what the birth weight was. And then obviously what happened right around that time of birth, because a lot of times in genetics, things are blamed on hypoxic ischemic encephalopathy, which may actually be triggered by an underlying genetic condition, especially metabolic disorders, for example. So it's very important to know what was happening around that time, how the initial feeding history was, whether the baby was able to suck normally, whether they fed by bottle or by breast, and then whether there were any neurological concerns specific to muscle tone, seizures, etc., and so forth, movements, abnormal movements. And then, taking on further history, a developmental history is key in pediatric genetics, because really the developmental trajectory rules out a lot of conditions. If you've got developmental regression, that leads to a host of extremely, different conditions compared to kids who actually slowly continue to attain their milestones. What medical issues were there specifically, because specific medical issues can alert you to a particular syndrome. The growth chart is the pediatrician's best friend and can really, really guide you as to what's going on, whether there's excessive weight gain or improper weight gain, etc. How the child's schooling and socialization is going, because sometimes that's actually the time when people pick up that something is wrong and that there may be developmental delay or intellectual disability, whether there are any specific vision or hearing issues, because those are key senses in development. And then just a thorough review of systems from head to toe, just to make sure if there were any clues that weren't missed. On a family history, you really need a 3-generation pedigree. And you want to specifically inquire about consanguinity. One thing I've learned in our culture is that people may not immediately be upfront about consanguinity, and you have to ask specifically if they're cousins or not. Sometimes people are from the same community and they may not identify themselves as consanguineous because they're not cousins, but if they're from a closed community, like a community from a particular religious a sect that only marries within its own sect, that could be a risk factor for consanguinity right there. Whether there's any family history of congenital anomalies, developmental delays, specific mental health issues, etc., and any unexplained childhood event or death should be noted in the pedigree. You can see that geneticists and genetic counselors love these kind of detailed pedigrees, because once it's documented, you can actually add on to it, and it really lays out, once a diagnosis is made, who else may be at risk. And obviously the mode of inheritance can easily be discerned once you've taken all that information. We, in our part of the world, see highly consanguineous unions and very, very complex pedigrees, as this one that you're seeing. So be prepared sometimes to go this much in detail, because that's maybe where all the clues are, and your diagnosis will be made based on this. On your examination, you want to be quite thorough. And I think this is, again, where, just 5 good minutes of a good physical exam will save you tons of money, tons of time, and really, really a good investment in doing that. So do the basics, specifically with regards to facial features. Note even the presence or absence of the following, whether there's coarse features, whether the eyes are normal or not, whether there's anything unusual with the ears, nose, lips, mouth, jaw. So again, this really is sort of your dysmorphology lecture going on. But moving on from the facial features, even other organ systems like the chest, the abdomen, the genitalia, the extremities become very, very important. Obviously, if you've already generated a differential based on the history and the family history, then your physical exam will yield much, much more. And a lot of these you'll see coming up in pictures in further syndromes that I will show up. There are good resources available. The Smith's textbook is always a ready available resource, although most people go online now. There may be a new addition to this since the last time I looked, but this was the last one that I had used. And then, the online Mendelian inheritance in man. This is a huge resource. So it started off, traditionally books. It was actually called MIM, the Mendelian inheritance in man. started at Hopkins by Dr. Victor McCusick. And now we've got 50 years of OMIM, as you can see, and you'll whenever you log on, you'll see this logo coming up. So I encourage people to really go and have fun with this website. It will be your best friend. I go to this on a daily basis. And if for some reason the internet's not working in my clinic, I have a very, very tough time generating a good differential. There are other resources as well. Some are paid subscription-based resources. Others are free. And there's an excellent app out there that people can play around with called Face2Gene, where you can basically take a picture of a patient, and through artificial intelligence and databases that have logged multiple pictures of multiple syndromes, a heat map is generated to generate a differential diagnosis. And this is an ongoing process. And then obviously there's really no replacement for experience. The gestalt of the experienced clinician really tells you a lot. What are the diagnostic tests, right? So you have your standard radiological and biological, biochemical markers that can help and should be used. But then there are very specific genetic tests, and I'm going to go into a little bit of detail because that will set you up for when we do the cases as to what tests should you do. So, you know, the bread and butter karyotype has been around since the late 50s, and pretty much the same way we do it, used to do it then, we do it now. But obviously there have been advances, and more advanced tests in the karyotype have come in. You have a focus test called fluorescent in situ hybridization of FISH. When you know what to look for, that's what you go for basically microdeletion or microduplication disorders. And then the chromosome microarray basically allows for you to essentially do millions of FISH tests on one slide and look at millions of loci rather than just one locus that the FISH test does. So we'll talk about that as well. And then, you know, you can do specific mutation analysis through traditional old school sequencing, or, you know, newer techniques, which we'll introduce you to. Gene specific methylation, multiplex ligation probe amplification can be done specifically to look for copy number variation within the gene. And then single gene sequencing is hardly ever done now, because we're really going for NGS panels, next generation sequencing, which allows you to do multiplex sequencing, multiple panels, multiple genes can be sequenced, because usually your differential will not include just one gene. There will be a few, but you can go for single gene sequencing. And then obviously whole exome or whole genome sequencing when you're faced with a diagnostic dilemma, or the diagnostic possibilities are so much that this actually is the most cost-effective way to go on. I leave this on because this is the menu of tests available to the clinician today. We may not use every one in every patient, but if you know which ones get you the best diagnosis, you won't waste resources and you'll do the best test available. We also know that these advances are ongoing, and the first genome took 13 years and $3 billion to be sequenced, and now we can sequence a genome in less than a day for less than $500. So really, really amazing advances, and I'm sure more tests will come up, and more they will for sure become more accessible, and we hope that they become very accessible in our part of the world. I know there are people in the audience today like Farhan, who are working very, very hard to make that happen for us. So let's talk a little bit about the three basic cytogenetics tests, the karyotype, right? So the karyotype is really your oldest school whole genome test, but it's low resolution coverage. Anything less than about 5 megabases that's deleted or duplicated will not be able to be picked up. So you'll pick up, you know, aneuploidies or trisomies or monosomies, but you will not pick up microdeletions. For that, you have site-specific FISH testing. And really, it's very, very high resolution, but you have to know what you're looking for. You'll design the probe for the area of interest. In this example, this is chromosome 22, Q11.2 deletion. And as you can see, this is the normal chromosome 22, and this is the probe at 11.2. On this chromosome, the 11.2 probe does not light up, which means it's deleted, and you've got your diagnosis. And then you've got chromosome microarray, which basically mixes the best of both worlds. It gives you whole genome coverage at very high resolution. So this is now actually called the molecular karyotype. And what it allows you to do is basically allows you to look at a number of loci, I mean millions of loci essentially, all in one slide, and quite cost effectively. And in this example, as you can see, there is actually a duplication at chromosome 11 Q at the distal end of the gene, which could be related to the syndromic diagnosis in the patient. So these are old slides from a very old lab that actually doesn't exist, but this is a patient resource that I use to teach my students and actually my patients. So I'm using it here because people sometimes get hung up with these three tests: the karyotype, the FISH, and the microarray. So what tells what? So these are your chromosomes when they're sitting randomly, in your nucleus. And when you see them, on the karyogram, that is basically an artificial way to line them up and see and count them up. Basically, what you're looking at is basically the encyclopedia of life. You're looking at the complete set, and what you're looking for is 2 copies each from chromosome 1 till 22, and then the XX or the XY for male and female. This is essentially the normal karyotyping. And when you've got a extra copy of chromosome 21, like you do in Down syndrome, you'll see it here as an extra chromosome, completely out there, so very easy to diagnose. By the same token, in Cri-du-Chat syndrome, when you've got a 5p deletion, it's such a large deletion that a karyotype will actually pick it up. But what if a small page of your encyclopedia or just a few pages have been torn off? That's basically what a chromosome microdeletion is. That will not be picked up on a karyotype because it's not high resolution enough. Alternatively, if there's a Xerox or a copying error and you've got multiple copies of the same page, again, your karyotype will not pick it up. And that's where your FISH test, knowing what page to look for, comes up. But your microarray is actually your best friend over there. Because what the microarray does is when you don't have a hypothesis, you can actually look at all of these loci all along the chromosomes and basically get your answer in a very, very cost-effective manner. So the chromosome microarray becomes the go-to test anytime you see a baby with multiple congenital anomalies, or you see a child with intellectual disability or autism spectrum disorder. So moving on, when we look at a gene, there are many different ways to look at a gene, right? So you've got the coding region and you've got the non-coding regions in the middle, right? And your central dogma of genetics tells you that the introns are basically spliced out. You've got your messenger RNA, which includes only the coding regions, the exons, or the exome, if you include all the genes. And that really is what leads to protein synthesis. So when you look at a gene, you look at the genetic code, you're looking at all the A's, T's, G's, and C's, and basically the triplet code actually encodes specific amino acids which make your proteins. So everyone knows that any mistake in this genetic code may either lead to a stop codon, which will be a nonsense mutation, or it may lead to a different amino acid being produced, which will be called a missense mutation. So in that situation, when you do a sequencing test, it really helps you focus on these A's, T's, G's, and C's. There are different ways to sequence. You can have your traditional Sanger sequencing, which is now actually considered quite expensive and laborious, and most people for most diagnoses will go for next generation sequencing. And when you do next generation sequencing, you can be panel specific, or you can actually go for exomes and genomes. As you may already know, the exome, the coding region of the gene, is actually only about 1 to 1.5% of your genome. So whole exome sequencing is much cheaper than whole genome sequencing and much, much less laborious. So these are both have come up now as mainstream clinical tests now. So I'm throwing them out there for people to just be familiar with. And I'm sure we'll have further webinars talking about specific details on how these tests work. So moving on, clinically, how much do these tests cost? So whole exome sequencing now in some labs can be as cost effective as about a little over $1,000 or $2,500 for a trio, and whole genome will be somewhere between $5,000 to $8,000. So it's typically done ideally as a trio-based test where both parents and the patient are tested, and they're thought to be ideal for diagnostic odyssey cases. And if you spend enough time with a geneticist or a genetic counselor, you'll realize that the diagnostic odyssey comes to us almost on a daily basis, and we're scratching our heads sometimes, and we're trying to figure out which specific gene panel to do, but sometimes we're at a loss and we go for exome testing at the outset, and sometimes for genome testing. The success rate, though, is not 100%. So even if you look at all the genes and all of their coding regions, your success rate is still somewhere between 30 to 60%, meaning that there's a lot unknown, and techniques and other things in non-coding regions may actually be playing a role in the pathogenesis. We don't know just yet. One of the big problems with sequencing many genes together is that you expect to get a lot of variants of uncertain significance and incidental findings. And I think that's challenging. What's also challenging is our discussion so far has focused on nuclear DNA, but then there's a whole alternate set of DNA called mitochondrial DNA, and this leads to its own specific set of disorders called mitochondrial DNA-based disorders. And if you're going to look for these, then you need to do specific testing for mitochondrial DNA, and your nuclear genes will not help you over here. We also have certain genetic disorders like Fragile X syndrome, myotonic dystrophy, spinocerebellar ataxia, that are due to triplet repeat expansions. And the tests that I've shown you so far will not pick those up. So I think that's one of the key take-home messages, that each test has its usefulness as well as its limitations. Specific triplet repeat testing to look for your specific diagnosis. So if you're not looking for it, you will miss it and your test will come back negative. There are certain disorders such as Prader-Willi-Angelman syndrome, for example, that are due to genomic imprinting, and very specific testing such as methylation-specific PCR or MLPA or uniparental disomy studies can sometimes need to be done. Sometimes they're due to deletions, and FISH or chromosome microarray will pick them up. So again, very, very specific. You need to know your diagnostic yield for these tests. So I'm going to take a little break over here, and then we'll go straight to the cases. But I've kind of given you a whirlwind tour of the tools that you have. I don't expect people to remember everything I've talked about. I think this was merely an introduction, and really just to let you know that genetic testing is a somewhat complex undertaking, and it should be done in partnership with a team of geneticists or genetic counselor. I know access is a huge issue, even in the US and Europe, let alone in Pakistan, where you have such few people. But I think the PSMG is trying very, very hard to build that capacity over here so that genetic counselors and geneticists can be accessible to people. And I'm sure that through web-based resources, et cetera, and so forth, we will create a genetic literate workforce that will be able to take this challenge on, because in our population, as you know, we have a huge burden of genetic disorders. So I'm going to move to the cases now, and then I'm going to take questions at the end. So this is case number 1. A 38-year-old mother has delivered a term baby. The prenatal ultrasounds were showing intrauterine growth retardation, but no specific anomaly had been picked up. And when the baby is born and the newborn exam is done, you are told that there are multiple things going on. There is microcephaly, microphthalmia, there's a cleft lip and palate. There are some scalp defects that you see in the picture over here. There is polydactyly that is seen. Kidney ultrasound shows a horseshoe kidney. There is an omphalocele, and a cardiac echo done reveals a very large VSD and ASD. So I'm sure that people in the audience are already generating a differential over here. So the question really is that as we see this, newborn with multiple congenital anomalies, what's your differential? I think the take-home message here is think chromosomal. Whenever you've got so many things going on, it's likely to be a large imbalance. So think chromosomal. It could be trisomy 13 versus trisomy 18. There are some other chromosomal imbalances. One could make an argument that the DiGeorge syndrome could present like this. And then there are other named associations, such as the Bacterial association with its specific defects that can be seen. So I think it's good to generate this type of differential before you hone in specifically on the diagnosis. And the question for the audience next is what to do. And you're right, a karyotype, the old school test, will actually get you a diagnosis. And as you can see over here, 3 copies of chromosome number 13. This is classic trisomy 13 or Patau syndrome, as it was known before. And all you need to do to diagnose this condition is just do a karyotype. You don't need to do NGS. You don't need to do whole exome sequencing. You know, a straight up karyotype, because the clinical characteristics, the clinical features were so characteristic, should be good enough. The big, and you know, on the differential is trisomy 18. As you can see, there may be some clinical overlap, but the you know, clenched hands, the rocker bottom feet, you know, the cleft lip and palate is not a very classic feature. The scalp defects are not a very classic feature of trisomy 18. So you know, you rule it out. And again, your karyotype will essentially rule that out too. So here in this diagram, you can see trisomy 18 show up over here. So again, it's good to know what's on your differential and what the characteristic features are, but with enough experience, you would be able to at least have a hypothesis as to what your karyotype will show. The problem with a karyotype is that it takes time. In our setting, it takes about almost 2 to 3 weeks. In the best labs, it may take 5 to 7 days because cells need to be cultured. But a quick and dirty test that can be done while you're awaiting the karyotype is an aneuploidy FISH. Because that will actually have probes for 13, 18, 21, X and Y, and can actually give you a quicker diagnosis. And actually, you know, if you have a probe for 22q on that FISH test too, that will be ruled out too. So again, the 22q deletion syndrome has its own set of very characteristic features that are usually recognizable once you've seen a few patients. And the clinical course is much milder compared to the trisomies. The trisomies are usually lethal in the first week of life, although there have been reports now of some long-term survivors. And again, a karyotype will not pick up DiGeorge syndrome. As I've told you, there you'll have to do either a FISH or a chromosome microarray. So why does it matter? It matters because put yourself in the shoes of the parents of that little infant just been born. They were expecting a healthy baby who maybe was just a little bit, you know, growth retarded. And now you've got these multiple anomalies going on. What is the prognosis? Making a clinical diagnosis of trisomy 13 will really set you up for really making decisions on whether aggressive management should really be done or not, or whether you should go for comfort care. So unnecessary mechanical ventilation, unnecessary aggressive care in the NICU should not be done if that's your suspicion, because that can cause a lot of pain and suffering for the patient and the family. With this diagnosis, you can give them an accurate recurrence risk, and you can counsel them, because a lot of times, you know, especially with older parents, their family is complete and they're worried about the siblings of this child as to when they grow up, are they at risk for having children with similar conditions? And you can actually reassure them, if this is a true aneuploidy, that the recurrence risk will be very low. Case number 2. This is a 3-week-old infant who presents with lethargy and poor suck. There is vomiting, poor weight gain, respiratory distress, and on examination, there is hypotonia and hepatomegaly. You take a family history and you find out that the couple has already lost one baby due to sepsis very early on in life. And when you do initial labs, you find out that the baby is severely acidotic. There is ketosis as well. There is hyperammonemia, and the CBC shows evidence of neutropenia, thrombocytopenia, possibly, looking for sepsis. So, this presentation is unfortunately a daily occurrence in most NICUs in Pakistan and most likely elsewhere in the world too. What's the differential here? Here, the rule of thumb is treat for sepsis, but think metabolic. Do not ignore a metabolic condition over here, because this presentation at, the first few weeks of life is very, very classic for a metabolic disorder. And the differential here is really a handful of disorders. You've got your organic acidemias, you've got MSUD, you've got your urea cycle disorders, but the urea cycle disorders typically have ammonias that are greater than 1,000. and then usually, at least in Pakistan here, will be picked up quite late. So, this whole area of diseases is changing due to newborn screening in the developed parts of the world, but in our part of the world, unfortunately, we see a lot of kids presenting with encephalopathy like the baby in the case. And then other things on the differential should include mitochondrial disorders as well. The good news here is that your diagnostic tests are quite cheap and readily available in Pakistan. Urine organic acids, plasma amino acids can be done. Plasma homocysteine levels can be done to really do that initial metabolic screen that will help guide you as to what's going on. In this situation, the diagnosis was methylmalonic acidemia, because that's what the organic acids showed. Once you've got your biochemical diagnosis, all you need to do is do the specific molecular panel for that differential. And because methylmalonic acidemia is not a single gene disorder, it's caused by many different genes. So to know which gene, that's what you need to do. Why does it matter again? It matters because it's a life and death matter in this situation. An accurate diagnosis will set you up to do the dialysis, to do the treatments for hyperammonemia, to change the diet, to restrict the protein. All of those immediate day 1, day 2 type of things that need to be done in the neonatal setting can be done if your diagnosis is made. If it's the diagnosis is missed for even a few days, permanent brain damage is done, and then your long-term prognosis is really, really poor. And obviously, reproductive options can be given to couple for future recurrence risk as well. Case number 3. So this is a 6-month-old baby who presents with weakness. So again, an older baby coming to you now. There are no issues for the first 2 months that the parents tell you, but then the baby actually lost neck holding at 4 months, and then is currently not rolling over. So you can see there's at least a loss of motor milestones. A baby has also started having frequent choking with feeds and has been hospitalized twice with pneumonia, which actually sounds like aspiration pneumonia here. When you examine the baby is actually smiling and interactive, so it doesn't seem like an encephalopathic baby. Seems more like a baby with normal cognition, but with a severe hypotonia and motor delay. When you examine the baby, you confirm that there is hypotonia that's severe and generalized with absent reflexes, and on careful examination, you see tongue fasciculations. What's going on over here? Again, the differential here is pretty tight. Spinal muscular atrophy, SMA, should be the first thought, but there are others as well, because I see so many infants over here being labeled with SMA with negative genetic testing, which actually is very sensitive. So don't label children with SMA until you've proven it, because congenital myopathies can present like that, congenital muscular dystrophies can present like that, even the congenital myasthenic syndromes and Prader-Willi syndrome presenting with hypotonia can overlap with features of SMA. How do you hone in on the diagnosis? First things first, you do an EMG, which will very quickly tell you that there's anterior horn cell dysfunction. A CPK should typically be normal in SMA. And then when you do the gene-specific MLPA, you will find that there will be deletion of typically exon 7 and exon 8 of SMN1. And in this situation, 2 copies of SMN2. The more copies of SMN2, there may be a milder phenotype. So that's why the test is done this way. The test results can be confusing sometimes, so please ask for help when you've done this test, because a lot of clinicians do order SMA testing and they need help with the interpretation. Again, why does it matter? Because clinical decision-making is based on the prognosis. If the disease is advanced by the time the child comes to you, you may decide for comfort care. Because SMA used to be an untreatable disorder. We now, thankfully, have targeted therapies available. They're extremely expensive and extremely hard to get hold of in Pakistan, but things like nusinersen, risdiplam, and now the gene therapy on seminal gene AB Parvovec, also called Zolgensma, is available and can be used. And obviously, it matters because reproductive risks and options for prenatal and pre-implantation genetic diagnosis can be made, because this is an autosomal recessive disorder with a 25% recurrence risk. Moving on, case number 4. So this is a 2-year-old male toddler with delayed milestones. Again, a very common presentation in the pediatric genetics clinic. You also are told that there is progressive stiffening of the joints, and the parents say that there's an enlarging belly. The baby is also progressively hairy compared to other siblings. The parents say they're unrelated. They have, on examination, you notice coarse facial features and a large tongue. You actually do confirm that there is hypertrichosis or excessive hair. And on examination, you confirm hepatosplenomegaly. You see contractures in the wrists, and you look for corneal clouding because your differential diagnosis does include disorders which could have corneal clouding, and there is none. So again, what's going on over here? What are your differentials? Again, you're thinking storage disorder, which most of you are. The real question is, which one is it? Is it Hurler versus Hunter versus Niemann-Pick versus a host of other disorders such as mucolipidosis and oligosaccharидoses, etc.? We also know that other single gene disorders other than storage disorders can overlap with the clinical features. So things like Cornelia-de-Lange syndrome can give you the hypertrichosis and coarse features, and Beckwith-Wiedemann syndrome can present this way too. What are your diagnostic tests? Again, biochemical testing can help. If you've got good urine chromatography, you will be able to tell which biochemical substance is being excreted in the urine. So heparin and dermatan sulfate being increased lead you to the correct diagnosis in this situation. You can actually do a very cheap and quick ancillary test. A spine X-ray will show you evidence of dysostosis multiplex, or in this case, anterior beaking of the vertebrae. People used to do enzyme testing, but it's laborious and no longer necessary, because once you have your differential homed in, you can actually do the NGS panel for the storage disorders and get to the diagnosis. Here, our diagnosis is Hunter syndrome because there is no corneal clouding and there was no consanguinity reported. So this is an X-linked disorder. And to differentiate this from Hurler syndrome, we'll show you some tricks. So Hunter syndrome can be quite tough to recognize early on because the features evolve slowly, and that's why the typical diagnosis is made around 2 years of age. But as you can see in this baby over here, the features are not very typical initially, but look at, as this baby has grown to an older gentleman, you can see the features become progressively coarse. You can see the contractures develop both in the distal joints as well as the proximal joints, and typically there is significant developmental delay as well. In Hurler syndrome, you will see corneal clouding, and some of the other features may be a bit more severe. Hurler syndrome may be earlier onset compared to Hunter syndrome, and this is an autosomal recessive disorder, and you will typically see consanguinity in the family history. So again, a lot of clinical overlap between the two, but a good examination, good family history will differentiate, and your testing, biochemical testing, as well as your further NGS testing will get you to the diagnosis. Again, the important question, why does it matter? Well, first of all, different disorders have different complications. So knowing what you're dealing with will be very important. There are some storage disorders that have no intellectual disability. So knowing which one it is will help you with the counseling. There is now enzyme replacement therapy for not all, but some storage disorders. So that can be instituted. Again, extremely hard to do in Pakistan because it's a lifelong treatment, and it does not cross the blood-brain barrier, so does not help with those disorders where there is cognitive impairment, but it does help with the systemic complications. Counseling can be done, obviously, to set up these parents, because these parents need a lot of support, because these children have long-term needs. They usually survive long-term and can really drain the family's emotional and financial resources. So giving them respite is very, very important. And obviously reproductive decision-making and counseling can be done once a diagnosis is made. The differential diagnosis should also include Cornelia-de-Lange syndrome, as I mentioned, and you can see the cynophorus, which is very, very characteristic, the unibrow, the microcephaly, the coarsening of the facial features, but some of the other features are quite unique and not typically seen in the storage disorders. So a good clinician would be able to differentiate between Cornelia-de-Lange and the storage disorders, again, and the lack of the organomegaly and the lack of the joint contractures should help. Beckwith-Wiedemann syndrome is easy to diagnose. These kids typically will not have the developmental delay and the progressive developmental issues that the other kids mentioned in the differential will. They'll have the large tongue. They may have hypoglycemia due to hyperinsulinemia, which is usually transient and managed without any need. The main complications is embryonal tumor formation, and they need to get specific surveillance done for that. Case number 5. We've got about 5-10 minutes to go, so I'm going to go through the cases here. This is a 3-year-old child with multiple brown patches on his skin. These became noticeable around 6 months of age to the parents and now seem to be increasing in size and number. And the father mentions that he has similar patches and skin nodules that are painless and have never bothered him. So again, most of you in the audience are thinking correctly. This could be NF1 or neurofibromatosis type 1. But the important thing to remember is not every patient with cafe au lait macules has NF1. NF2 can sometimes have cafe au lait macules too, although it's really a completely different disorder, different set of complications. The bilateral acoustic neuromas are really what bother people with the NF2. There is an overlapping syndrome with NF1 called Legius syndrome due to mutations in another gene called SPRED1. There is the McCune-Albright syndrome that causes very different types of cafe au lait macules. I'll show you that on the differential. And then sometimes people confuse NF1 with tuberous sclerosis because there are pigmentary abnormalities there, although the typical patient with tuberous sclerosis would not have cafe au lait macules. So, the good news with NF1 is that there's a very good, tight NIH-based criteria, which I'll show you in just a second. You can confirm your diagnosis with single gene sequencing for NF1, although that may not be needed purely just to get a diagnosis. And really, no specific imaging is required unless there are specific symptoms. NF1 is basically a clinical diagnosis. As I mentioned, the cafe au lait macules are typically smooth bordered rather than those seen in McCune-Albright syndrome, which have jagged edges. Those living in North America will be familiar with the coast of California reference to the NF1 cafe au lait macules versus the coast of Maine appearance with the McCune-Albright cafe au lait macules. The other thing is that the cutaneous neuromas can be, very, very widespread or can be just a few. The plexiform neurofibromas are more rare, but when present can be very disfiguring and very alarming if they're in a place which causes compression. A lot of times they remain there for the rest of the person's life without causing any significant problems. So again, knowing what you're dealing with can help you counsel. And really the follow-up for NF1 is a good clinical examination by someone familiar with NF1 and looking for blood pressure abnormalities, because pheochromocytoma can be a complication. Otherwise, you don't need specific imaging. I actually see in my practice people over-imaging their patients. A good eye examination will tell you whether there's an optic glioma that needs imaging or not. Otherwise, you don't need to do head MRIs. Other complications can happen too, such as the tibial the pseudoarthrosis in the tibia, which can actually be very, very problematic orthopedically. And the management, as I mentioned, is just surveillance. Most of my patients with NF1 do great and go into adulthood without any major issues. Although all of us in genetics have lost patients with NF1 due to significant complications. So even though those complications are rare, they can be life-threatening and they can be prevented if appropriate management is done. Tuberous sclerosis, again, is a condition, as I mentioned, can overlap sometimes, although they're actually not cafe au lait macules, they're hypopigmented macules that are seen, and typically confetti-like configuration is seen. These are the other complications that you can notice in tuberous sclerosis. I'd like to mention that there are now treatments for complications of tuberous sclerosis, because we know that this is part of the mTOR pathway, and drugs such as sirolimus and tacrolimus can actually be used to dampen down that pathway, and good outcomes with the subependymal giant cell astrocytomas and regression of some of these tumors has been seen. And there are ongoing studies to see whether the seizure disorder and the developmental delay associated with tuberous sclerosis can be amenable to treatment with mTOR inhibitors. So again, you make an accurate diagnosis, you give people treatment options. Here are the other complications that can be seen in tuberous sclerosis and the recognizing features: the shagreen patch, the adenoma sebaceum, and the cortical tuber seen on CT or MRI. Moving on, case number 6. So this is a 3-year-old child with unique facial features and developmental delay. The child is very, very social and has no stranger anxiety since a very young age. Has a hoarse voice. On examination, you notice periorbital puffiness, you notice some coarsening of the features, you notice a large mouth and prominent ears. You also notice on careful examination loose skin and joints and a prominent systolic murmur, and also high blood pressure. So again, your differential diagnosis is churning in your mind. What could this be? These features could be reminiscent of the Williams syndrome, although overlapping conditions such as Noonan syndrome, DeGeorge syndrome, Kabuki syndrome, all can be considerations. So how do you make a diagnosis? So, there are some ancillary tests that can help before you do the specific testing. Measuring a serum calcium, which can be elevated, not always, but usually in infancy it's elevated. Hypothyroidism is a common feature in Williams syndrome, so you can actually identify that. And the classic lesion in Williams syndrome is a supravalvular aortic stenosis seen on cardiac echo. Some patients develop progressive renal artery stenosis, which can cause hypertension, as in our patient. And the diagnostic test is a cheap, focused FISH test for looking for a deletion at 7q11.2. This deletion encompasses the elastin gene, and that's why you have the complications. You can see the characteristic features: the periorbital puffiness, the relatively large mouth, the slight coarsening, and the iris has a stellate pattern to it that in lighter pigmented individuals is seen much, much more clearly. You can see that as these individuals age, they tend to coarsen their features much more. The microcephaly can be a feature, and the mouth remains relatively large. These patients tend to have loose joints and the lax skin, as I mentioned, and they can have the lab abnormalities, as I said. These patients need to be progressively followed for complication of renal artery stenosis, and they sometimes need strong cardiac management for the supravalvular aortic stenosis. So again, setting up the family for realistic expectations developmentally is very important, because these kids are so social that they actually fall through the cracks, and people expect much more out of them because their verbal skills are much more than their non-verbal skills, and they can get into trouble that way. Noonan syndrome has its own unique set of features: hypertelorism, the triangular appearance to the face, the slight coarsening, the posteriorly rotated low-set ears, sometimes the neck webbing can be seen. And again, a different set of complications that you notice on the list over here. And so knowing your diagnosis will help you get to the right set of complications that you need to do. A molecular panel looking for all the different genes associated with Noonan can easily be done. And once you get a diagnosis, you can do a tailored approach to surveillance and treat and specific management of complications. Kabuki syndrome can cause some overlap. The characteristic feature is really in the eyes, because this is a reference to the Japanese geishas that do the Kabuki theater makeup, and the lateral aspect of the eyes being very prominently highlighted without any makeup in these patients is really why this patient was named Kabuki syndrome. And they can have their own set of complications with congenital heart disease and developmental delay. Again, why does it matter? Because knowing which syndrome tells you which things to look for and which roadmap to follow. And obviously, each syndrome has its own different set of recurrence risks. Coming to the home stretch now, this is the second last case, case number 7. We have a 19-year-old female now. Now we're moving on to the adult realm. This patient is tall with a thin body habitus, has been wearing thick glasses since very early childhood. Has had a heart murmur, but no one ever bothered to do an echo. And on examination, you see that the patient has a long face, high arched palate, dental crowding, long limbs, scoliosis, long fingers, kind of like a spider-like appearance, flat feet, and then loose joints and skin striae are present. So again, most of you are coming to the diagnosis. The differential at the top of the list is Marfan syndrome, but it does include disorders such as homocystinuria, Lewis-Dietz syndrome, Ehlers-Danlos syndrome, the various subtypes, as well as monogenic disorders that can present with aortic dissection and dilatation. So knowing your disorders and knowing which one to look for is very, very important. The ancillary tests that will help you are basically an eye exam, because if there's lens dislocation, very strong suspicion for Marfan syndrome, and a cardiac echo to really look at the aortic root and the mitral valve to make sure you're not missing anything that's extremely life-threatening over there. And the Marfan syndrome has its very own set of criteria, the revised Ghent criteria, and a good clinical examination can be done if you go to marfandx.org. The systemic score is listed. You can fit it in over there. Very easy to do this. I won't belabor the details, but there are very specific criteria for Marfan. There are Marfan overlap syndromes. So why does it matter? Because each syndrome has its different vascular complications. So, there are Marfan syndrome, which is primarily the aortic root, but Lewis-Dietz syndrome can have cerebrovascular dissections as well, and to know what to look for can actually save the life of the patient and their family members. In Marfan syndrome, now it's standard of care to offer beta blockers with or without angiotensin receptor blockers, because these may be helpful. Prophylactic surgery can be done for the aortic root, and you can identify family members before life-threatening complications happen. So again, a good diagnosis will lead to proper management that's guideline based. The Ehlers-Danlos syndrome with loose joints is on the differential, although there are so many different subtypes. Most people are labeled with the hypermobility type that typically has no vascular complications, but the type 4 or the vascular type of EDS, the type 3, actually, this is a typo, can really be very, very life-threatening and very, very aggressive. So I have to be very, very careful with this. Finally, case number 8. 32-year-old woman presents with a recent diagnosis of triple negative breast cancer. This is basically ER, PR, and HER2 negative breast cancer. Her mother died of ovarian cancer. Maternal aunt, the khala, had breast cancer, and the maternal grandfather had prostate cancer. So you can see on this pedigree that this is an autosomal dominant inheritance, and a very, very characteristic set of tumors is happening in this family. What's the differential here? Top of the list is BRCA1, BRCA2 related hereditary breast and ovarian cancer, but it could be others too. A more aggressive syndrome called the Li-Fraumeni syndrome due to P53 mutations, as well as Cowden syndrome and CHEK2, and there are many, many other genes now on the list for causing breast and gynecological cancers. So what's the best test here? Here you don't beat about the bush, you do the panel. Just doing simply BRCA1, BRCA2 sequencing is not good enough. You need to look at all the genes because you may be missing something. And all of us have been humbled when we see a gene that we're not expecting come up positive in a panel. Again, why does it matter? Because there are now gene-specific guidelines for surveillance and management. For that woman who's sitting in front of you, she can make an immediate decision of whether she should go for a lumpectomy or a total mastectomy if the recurrence risk in that particular breast is high. Also, should she go for a prophylactic mastectomy and salpingo-oophorectomy, or is that really not needed if a risk for other cancers is low? You can identify asymptomatic family members and after appropriate genetic counseling, test them, and you can offer reproductive risk management. So again, all the reasons to do genetic testing for this individual. So again, this is my last slide now. I'm summarizing this whirlwind talk by saying, get the basics right. A history and exam will save you, a lot of money and a lot of time because your diagnosis is staring at you after these two very, very basic things. If you've got access to good databases and you know how to use them, you'll have a differential in mind. Once you have that differential, know what tests are in the repertoire and which test will get you to your diagnosis. Each syndrome has a specific management, and each syndrome will require specific genetic counseling. So knowing your syndromes, knowing how to counsel is very, very important. And really the focus for everyone should be that our goal is to empower families to improve their quality of life. Really, giving them that diagnosis and forgetting about them, giving them that death sentence is not good enough. We need to empower them so that that diagnosis helps them, they take care of their family member, their child, helps them make their best decisions for them, not only for reproductive reasons, as well as for their own medical care. So with that, I'd like to thank the PSMG leadership. Really appreciate them giving me this opportunity to do this talk. I know it was kind of hurried and we really covered a lot, but I hope it was useful, and I'm very, very happy to take questions. I'm going to stop sharing my screen here. Thank you very, very much.
Excellent. Thank you so much, Dr. Kirmani. Thank you for that marathon run on common genetic disorders. I feel like I was sitting back in my advanced medical genetics course, but on steroids. Yeah, no, really, you have done a wonderful job in showcasing the importance of a detailed training for physicians and genetic counselors in Pakistan in hereditary cancer and other, genetic disorders. Wonderfully done. I hope the takeaway message here is that, of course, those 3 main points that you mentioned earlier, which is make sure that you are taking good family history, doing a good thorough exam, and know when to refer out. I think that's the key. And so without further ado, I would like to ask some questions that were brought up in our chat boxes, but I also want to ask a few questions for myself because I'm really interested. So Ansa Rabia is asking, does maternal stress during pregnancy have any role in genetic disorders in fetuses?
A very, very good question, and we get that very, very commonly. And the answer is very tough, right? So we know that the in utero milieu has its effects on the way genes are expressed. So epigenomic changes can happen and so forth. Whether purely stress alone will lead to a spontaneous mutation is thought to be extremely, extremely unlikely. So I think for all the conditions that I've described in my talk and the conditions that you are likely to encounter in a genetics clinic, to simply chalk that up to maternal stress during pregnancy would be wrong. But I think complex disorders such as type 2 diabetes and hypertension and all those kind of things that are polygenic and could have multiple programming effects on the fetus could certainly happen. So I think that's really the take-home message. Monogenic disorders, single gene disorders are typically not due to maternal stress alone.
Yeah, that makes sense. Would you say the same for chromosomal disorders like Downs and Patau and Edwards?
Yes. So aneuploidy, is basically a phenomenon that happens in the, usually in the maternal oocytes at a very early stage of development. And so we don't know all the factors that lead to that, non-disjunction, but we don't think that any specific stressful stimulus can cause it. It's probably a host of features.
Great. All right. So our next question is from Dr. Aisha, and I think she's looking for some resources in her area and wondering if you know something about this. So please tell us a little bit about genetic labs in Lahore or other major cities from where genetic testing can be done. So if there are any resources that you're aware of that you're
right. So, a basic karyotype can be done by most labs in most of the big cities in Pakistan now. So Lahore, Karachi, Islamabad, Peshawar. I'm not too sure about Quetta, but at least those main cities will have at least one lab that will do karyotyping. Also, some labs will collect at different centers in smaller cities and villages and will take it to their main hub and do the karyotyping over there. And so AKU does that. I'm sure Chuftai and all of these other labs that do karyotyping can do that too. Now, coming to more complex tests, that becomes tough because apart from a handful of tests such as the MLPA for SMA or for Duchenne muscular dystrophy, or the FISH testing for Williams syndrome or Prader-Willi syndrome, etc. very few of the genetic tests are available anywhere in Pakistan. So most labs have basically developed an outsourcing model where they are outsourcing it to a lab abroad. Some of those labs are in Germany, some of those labs are in the US, some of them are in other parts of the world. I think the thing that I'd like to tell all the providers and the potential people who order the tests is know the lab that these tests are being sent to and make sure that the quality of reporting is good. Because the quality of reporting at some labs is not very consistent. And some labs in Pakistan, unfortunately, are not being honest in saying that they're outsourcing, and they will basically print out a report and make it their own, which is unethical and wrong. So I think knowing which lab and what are the limitations is very, very important, because as we all know, there are very strict criteria as to what a genetic test lab report should look like and what all it should include and what are the wordings specifically that should go in it.
Yeah, couldn't add any more valuable information than what you have added. Obviously, we're more, in that part of the world, things are sometimes very suspicious, and you have to be extra cautious in how you interpret that data. And having a resource like yourself and Dr. Saqib in that area are very, very important. And PSMG is also available in those cases where interpretation of the data becomes very difficult. So, on our website, if you go to www.psmg.org, there's a comment section as well. So folks are able to go and ask questions that we may or may not be able to answer, but it is a resource that is available. Dr. Kirmani, of course, in Karachi at Al Khan is available, and Dr. Saqib in Lahore is also a key resource that we have come across so far in Pakistan. So thank you for that. Now, I have a few questions that I wanted to bring up before I go back to the audience. So we've talked about whole exome sequencing in Pakistan. In your practice so far, and how many ever whole exome sequencing tests that you have run, what are the percentages of variants of uncertain significance that you're seeing?
So the answer is almost every report has VUSs. Almost every report, okay? And I think we've all learned to ignore some of these, whether that's true, right or not, we don't know. But I think the take-home message from our experience, and I'm sure that's the international experience as well, is that if your phenotyping is good, if you've put in the right clinical features and given them to the labs, their pipeline that they will use to home in on the genes of interest will be much, much more accurate. And so I think it's really unfortunate, but I've noticed this in my practice too, and I'm guilty of it. When I cut corners on the phenotyping, I get an uninformative result. When you go back to the file, when you re-examine the patient, when you re-look at certain things and you let the lab know to specifically focus on these specific things. And I think in that case, the HPO, the human phenotype ontology, is very, very useful, because that's a terminology that the labs also use in their pipelines and clinicians use in their daily lives. That's very, very important. So I think VUSs can be minimized, because then you're not going to be looking at genes that are not of interest. But basically, if I were to expand that question to NGS panels, I would say, again, almost every NGS panel that I order will have a VUS or two. And you learn to ignore them if you've got a pathogenic variant that explains your phenotype.
No, actually, that was going to be my part two of the question, is if you were to compare a next-gen sequencing panel where you were targeting a specific set of genes as compared to variants of or whole exome sequencing, is there a difference in the sensitivity of the test in terms of the success rate? Do you have more hits on a panel versus on a whole exome sequencing because of the variants of uncertain significance that are so increased in whole exome sequencing? But I think you answered that question by saying that irrespective whether you're doing a whole exome sequencing or next-gen panel, the variants of uncertain significance in the Pakistani population are just going to show up, just because of how understudied our population really is. And to add just another sentence to that is, knowing your phenotype will make and break what happens. If you have a phenotype that is really not matching with some of the things, like for example, NF1 that you mentioned today, on hereditary breast and ovarian cancer panels, they add NF1 for no real reason, right? And every once in a while, I would say, actually more often than I would like, we see so many VUSs in NF1. So that is just an example. All right, I'll move on quickly. Consanguinity, what are your thoughts on that? And I want to, again, I know it may be a little controversial to sometimes talk about it, but a lot of the syndromes that you mentioned have really no connection to anything hereditary. Forget about consanguinity, right? And so just in a lot of times, especially when I've been counseling patients in Pakistan, the when we say, you know, cousin marriages are common in Pakistan, we know that some of them, yes, will have certain concerns, but a large majority of them don't. And so my question here is two parts. One is the concept of newborn screening or pre-conception counseling. What are the upcoming or current status for that in Pakistan? And what, just in general, what are some of the tips that you can provide us with how to counsel patients that are consanguineous?
Right, that's quite a mouthful. So, you know, I'll do the easy question first, which is on the NBS. So, you know, universal newborn screening is going to be extremely challenging in Pakistan, because you need a very, very good healthcare system before you do the screening. You can put your blood spots and you can send them somewhere, but if you don't have the necessary safety nets to actually do something after the diagnosis, there's really no point in investing those resources in newborn screening. So I think the newborn screening is a healthcare system issue. It's not just a genetic test issue. I think that's where people make the mistake of going for newborn screening as just a test. It's not a test, it's really a health system overhaul. And with the strain on the health system in Pakistan, you got to be very careful. So I think private health systems like ours at AKU, we've started congenital hypothyroidism a few years ago, and we've added biotinidase deficiency and a few others now. So we're doing it, but we're only doing it within our health system. It's impossible to start offering it at even the province level or the city level. It's going to be much harder. Mm-hmm. Now, consanguinity and how do you counsel? I think it truly depends on the family history. If you've got a phenotype that is consistent with a particular disorder, then doing, at least, looking for that individual with that phenotype and testing them to confirm that diagnosis is the first step. If you don't, then I've been using the comprehensive carrier screen available at Invitae that covers about 300 disorders or so. The problem I have is that it will not report VUSs. So, and we expect that certain VUSs in our population will be pathogenic. Our exome testing has shown that. So, that's a tough situation. So I think the generic counseling given to consanguineous couples is that, the likelihood that something wrong will happen is overall, low, but relatively high compared to non-consanguineous unions, right? So I think the problem with consanguinity in Pakistan is that it's very deeply stigmatized, and the educated people tend to look down on people who are from consanguineous unions, and I think that's setting us up for trouble. So as genetics providers, we should be very open, and we should be very, non-judgmental about couples sitting in front of us, and there's a tendency to make people feel bad. I've had stories where people, the young couple is sitting there and their parent is in the room and they'll be told, "Aapne kyun shaadi ki inki? Aapko to pata tha ye cousins hai." And that's just ridiculous. No one deserves that kind of, insult, and should not happen. I think the main thing is appropriate counseling, giving them options, and carrier screening. Once you screen, that there's a 25% risk. There is, every reason this couple can have a healthy child. Yeah. And be free of a devastating disease. So I think that should be offered. Those are my views on it.
Thank you. That's wonderful. I have a relating question from Sanila Khan. She's asking about specifically for babies with PKU in Pakistan. Are there any facilities for maintenance of individuals with similar metabolic syndromes that need lifelong checkups and maintenance? Right.
So managing metabolic conditions is extremely challenging in Pakistan. First of all, there's really only one trained metabolic geneticist for the whole country. And Dr. Bushra Afroz, she's in AKU. Even within AKU, the challenge is the specific formulas that are required and the dietary restriction. PKU is still not too bad, because once you can restrict the phenylalanine and give the specific formula, at the early stages of life, you can liberalize things a little bit as the infant and the individual gets older. With some of the other disorders like methylmalonic acidemia, MSUD, urea cycle defects, it is hugely challenging. Lysosomal storage disorders. I mean, enzyme replacement therapy is just non-sustainable. It just can't happen. Even if you have some, compassionate use program from some drug company that gives it for 6 months or a year, we've done that. People get fatigued by just having to come weekly for the infusion. They'll stop coming. So, unless, the key is prevention. I think if we can prevent it, we can be successful. And then maybe some specific therapies like targeted therapies and gene therapies and so forth, expecting that liver transplantation for urea cycle defects will be the savior for these patients. That's not going to be practical solution for most people in our setting. So we got to be very, very careful.
Mm-hmm. Yeah, thanks for that. Next question is also relating to pre-implantation genetics, and this is from Dr. Shahnaz Hussain, and she would like to know what tests can be used in pre-implantation genetic screening in IVF settings, and what is the status of that in Pakistan? Are there any institutes that are doing pre-implantation genetics?
Right. So, I'll talk a little bit about prenatal genetic testing first, because that's the more simple one. So if you're in the prenatal genetic setting, where basically you're either obtaining a sample for chorionic villus sampling or amniocentesis, you basically will do the specific genetic test that you're looking for, right? And so you could either outsource that DNA or outsource the amniocytes or do a karyotype or a fish or whatever else is available locally, so you can do that. The problem in Pakistan is with genetic testing in the IVF setting, in the pre-implantation setting, because we do not currently have the technology to extract that single cell and the DNA from that single cell, for pre-implantation genetic diagnosis. The most that I've heard happening in Pakistan is, basically XY aneuploidy testing or, trisomy 21 aneuploidy testing in the pre-implantation setting for IVF. I have heard, but I'm not sure, that the Hamid Latif Hospital was offering more specific testing in partnership with a lab in Europe, I believe in Cyprus. But again, I have yet to meet a patient who has sent that testing and come up with a report. So people may know more about this than I do. I think it's just hugely challenging, because extraction of that DNA is what's a problem from the trophoblast, and from the 16 cell stage, in Pakistan. So maybe as the technology evolves, that can be done, but I'm not aware of it being routinely done right now.
Okay, all right, very good. Next question that we have is from Hassan bin Tariq, and he would like to know, how can we proceed to continue in genetics as doctors, as few teaching institutes and training programs in Pakistan offer genetic training in medical genetics?
Yeah, this is the $1 million question. I think PSMG has that at its heart of its mission, right?
Yeah.
So I think we've troubleshot this one, and the answer is there are multiple models that will have to be used. One is the traditional model, where you will have to train geneticists and genetic counselors the way they're trained in other parts of the world, either through a master's program for genetic counselors or a residency or a fellowship program for geneticists. And that currently does not exist in Pakistan for either counselors or for geneticists. The plan is through CPSP to start that, but starting a new program takes years of planning, as well as core faculty. When you don't have faculty to teach, how will you teach the trainees? And so I think that's really the big challenge. So I think that core critical mass of people needs to be here first, and then things will happen. I think the alternate, which can be considered, which is again debatable, is that you teach a little bit of genetics to different care providers in their setting, so that the obstetricians know what they need to know in their setting, the oncologists need to know what they need to do in their setting, and you kind of give them a resource to lean on, either virtually or in person, and you have that two-way conversation. I'm all for that kind of model, but again, requires time and resources and good planning.
Mm-hmm. Yeah, and I thank you for that shout out to the PSMG efforts, because that is exactly what is at the core of our mission, is to provide detailed, very, very thorough training to individuals in Pakistan. We're starting off from that genetic counseling perspective, because many of us are genetic counselors, but also, of course, training the geneticists, for those who are able to go abroad, like yourself and Dr. Ijaz, to gain knowledge and then come back to Pakistan like you did, of course, is not only commendable, but needed. So we are very thankful for some of you that are able to go back and do the hard work. Next question is from Dr. Imrana, and she would like to know what percentage of the syndromes that you presented today have been seen in the Pakistani population. I think they're just wanting to know some stats about,
Well, the answer is every single one.
Yeah.
But the problem is we don't have good statistics, because we don't do surveys like they do in other parts of the world. So everything will be anecdotal, and I'll tell you how you need to be careful. You'll hear people say, the most common metabolic or the most common genetic condition in Pakistan is thalassemia. You'll hear that over and over and over again. Mm-hmm. And the real reason for that is patients with thalassemia are recognizable to anyone who is not a geneticist. They will be recognizable to the adult physicians, to the pediatricians, to the hematologists, etc. These patients don't die in the first few years of life. They unfortunately take a long tumultuous course and die later on. So they're in front of you. They keep coming back to you. So it's really a prevalence issue, not an incidence issue, right? And people can make statements that thalassemia is the most common genetic disorder in Pakistan, but that's a flawed statement, because we don't know. Maybe there's some other lethal inborn error of metabolism that occurs just as frequently as thalassemia, but the babies die in the first week of life. So the answer is we don't know. My take-home message there is everything is common in Pakistan. We have a huge population. We have a huge birth rate. Even autosomal dominant disorders that are present in 1 in 5,000, 1 in 10,000 individuals in the Western population. There will be so many cases over here because we have such a huge population. Yeah. So everything is common in Pakistan.
Mm-hmm. Yeah, no, that's a wonderful response to this very loaded question. Like, there was no way I was going to say, how do you know that there's 1 in 500 children in Pakistan are being born with Down syndrome? That's an impossible question to answer. Okay, and then the next question is from Farhan. Farhan would like to know, this is Farhan Bukhari, a friend of ours, would like to know, does your group keep track of patients' genetic testing and update and notify them if they are clinically relevant, or is that something that the labs take care of, like Invitae, for example? I think he is referring to the variants of uncertain significance in particular. If they are reclassified, is there a way to inform you, first of all, and then how do you inform the patients?
Yeah, excellent question, Farhan. So the answer is, I really feel it is the responsibility of the clinician to do this and to figure, and obviously the lab does it at their end, but how do we make sure that the patient gets an update? In clinical practice, when we are left with variants of uncertain significance and we don't have a diagnosis, we typically say, come back to us in 6 months, come back to us in 1 year. Mm-hmm. In a busy practice, it's impossible to keep every patient on your radar. The lab, such as Invitae and others too, will email you once they've reclassified a variant. Everyone knows the data suggests most reclassifications are from uncertain to benign. A few are from uncertain to likely pathogenic. So those obviously are the very, very significant ones and ones you don't want to miss. But I think that at least annual follow-up and setting that up to make sure that that patient comes back for follow-up is the way to do it. The lab does empower the patient to be able to access their portal, and they can actually access their portal and get updates too. So that's another safety net that can be created through the lab.
Yeah, in most cases, from at least what I can tell you from my industry experience here, is that initially, I want to say a year or so, two ago, couple of labs were in the process of keeping the databases and keeping their variant of uncertain significance updates happen frequently every 6 months or every 1 year. They would go back and look at all their VUSs, and they would, have huge resources allotted to that massive effort, because you can imagine, hundreds and thousands of these variants are being looked at a time. And very recently, majority of those labs have stopped doing that. And the reason for that is, of course, the manpower is just not there. And like you said, majority of them are getting reclassified from VUSs to benign or likely benign. And so for those reasons, and for reasons that, just human power is not there yet, and AI is in development to take on that huge, massive endeavor. And so I think at the moment, the responsibility of VUSs and reclassification is divided between the clinicians, the patients, and the laboratory. Because when a patient calls the doctor then calls the lab, and then the lab knows, oh, okay, we know that there's an interest in reclassifying this variant. Let's look at it in a little bit more detail, as opposed to looking at many more. So thank you for that response, and thank you for the question, Farhan. Okay, and our last question is from Sanila Khan again. She's asking specifically about the recent health insurance mandate in Pakistan. So her question goes, talking about the Pakistani health system, there's supposed to be an introduction of state mandated health insurance in the works. In your opinion, what prenatal genetic tests should be added to that insurance plan, provided that testing labs becomes available nationally?
That's a very good question. And, it could be debatable, whether we want to use our limited resources to spend on prenatal testing. But I think if you were to choose one, probably the non-invasive prenatal screen, or the NIPS test, would probably be the ideal one, because number one, it's quite cost effective. It's still, again, not available in Pakistan. We outsource it, but as opposed to most tests that cost about $250, this test is actually $99 at least one lab. And so really for about 16,000 rupees, you could get it. If that technology comes to Pakistan, it can actually be done at a very cheap cost over here. So I think probably the NIPT or NIPS test would be the one that you could do. But again, it's also done with appropriate counseling, and not every pregnancy needs that test. So that's an important thing to consider, that there's no universal genetic test for every situation, especially in the prenatal setting. If a couple is not interested in termination of pregnancy and is okay to wait till the baby is born, there is absolutely no reason to offer them any testing and unnecessarily cause problems in their pregnancy.
Yeah, right. Okay, and our next question, and our last question is, again, we are running out of time. Are there any institutions or training programs offered in Pakistan that you are aware of? What are your thoughts?
So I think we addressed that a little while earlier, that there are none in genetic counseling and in clinical genetics. Now, you will have obviously a lot of genetics being taught in all the major universities in Pakistan. But again, most people are being taught human genetics in the non-clinical setting. Yeah. Unfortunately, there are very, very few universities that have partnerships with good hospitals. There are investigators and PhD scholars within those universities that are reaching out to clinicians, and there are opportunities for master students and postdocs to work with patient data, and that's happening, but it's happening rather slowly. So I think I would contact the different genetics programs at the major universities in Pakistan and see what they can offer in terms of things in the research setting. The clinical setting, it will take much more time to offer a specific training.
Yeah, I wanted to say one more thing, that recently we have received a really good project from the Gomal University, and I hope I'm not butchering the pronunciation, but they have at least in the works of a certificate program in genetic counseling, which is a one-year program. What they are planning to do is to, of course, have, again, no clinical aspect to it, but at least having some theory for this is, again, for providers that are MBBS doctors that can take this course at the Gomal University, where they can learn about the technology and all the wonderful things that you went through at the speed of light today. They could probably take a much more in-depth look into that and try to get their hands on some of that information, while it may not be available in clinical setting, but at least some theory is better than none at all. So with that, I will thank you so kindly for having first of all, the interest in this program, and of course, the training and all of that, and these video series and the lecture series is a big part of that as well. Of course, when you're going through some of these things really quickly, pausing and rewatching is the way to go. And I encourage everybody who is listening to this and watching this to do that, to pause, take notes, and go over it over and over again, because that's your resource that will be available. And all you have to do is go to www.psmg.org/education, and that's where you'll find all these recordings. This was our seventh lecture. And again, I want to say thank you so much, Salman, Dr. Kirmani, for taking the time to be with us today and answering all those wonderful questions. Thank you, and have a good evening.
Thank you, everyone.
Khuda Hafiz.
Assalamu alaikum.